Hello friends, good evening. Today I am talking on a topic which I really didn't like when I was a PG, even when I was a junior staff. I always avoided this topic. I requested the HOD not to give me this topic. But Dr. Pratap asked me to write a chapter on this topic, and I had to write a chapter. But that time also, I didn't like it so much. But after writing the chapter, I understood a little bit of this topic and started liking it. But when in one of the ASCOGs, they said you must talk on this topic and only you can do justice for this. It was like a challenge for me, and I went into depth of this, tried to understand this topic, and then it became my favorite topic. Unless it becomes your favorite topic, you can't give a good lecture on this. So the challenge here is so distressing to the parents to know whether it is she or he when they get a genitalia like this, or like this, or like this. They would be anxiously waiting to have the child of their preference, but then when they don't see what they want, they will be really in great distress. So we need to tackle this together with them. The earlier terminology was so harsh. It was called intersex, but now we call it disorders of sexual differentiation. I'll be talking on approach and management of this. Why I said it's a harsh terminology, because it is frightening and imprecise also. It's wrong to say that there is intersex or hermaphrodite. Then what is actually DSDs? It's a group of conditions in which a person's external genitalia and internal reproductive organs do not match. So don't call them intersex or don't call them hermaphrodite. It is so insulting. Yes, there is a mismatch, but that can be tackled. When we say DSD, it includes anomalies of the genitalia, and not just that, which is considered genital sex, reproductive ducts, which is reproductive sex, and gonads, that means gonadal sex, and sex chromosomes, chromosomal sex. So there's so much in determining the sex of a child, not just the external genitalia. The child should have matching reproductive organs and the gonads and also the chromosomes. Before I go any further, I want to spend at least good amount of time on this particular slide, because this slide will help us in understanding the entire gamut of problems. How actually a development of typical male happens. Because right in the beginning, even though there is a chromosomal endowment, the child is in a way, or the fetus, I should say, or the embryo is some sort of unisex. Just having an endowment of 46XY is not enough. You must have what is called Sry gene located on the Y chromosome. Yesterday, I made a brief mention about it. Today, because I wanted to talk in detail about it today. This Sry gene writes a transcription which will induce bipotential gonads to differentiate into testes somewhere around 5 to 6 weeks. Till that time, gonads can go either way. So it's a Sry gene that writes the transcription to convert that bipotential gonads into testes. Now, once the gonad becomes testes, then it will secrete Mullerian inhibiting substance, MIS, and thus there would be regression of Mullerian ducts. Otherwise, in the early embryo, all the ducts are there. They have to be encouraged to develop into a particular system. So here the Mullerian inhibiting system will suppress the Mullerian ducts. That's why there will be absence of uterus in men. Not just that, testis will also obviously produce testosterone and androgens. They would do two things. Number one, they would convert Wolffian ducts into spermatic ducts, and that's how we would get sperms. They would also have an influence on undifferentiated external genitalia to develop into typical male. So what is the starting point? Sry gene, which will change the gonad into testis. Then testis will produce MIS and make sure that the Mullerian ducts don't develop and uterus won't happen in men. It will also convert Wolffian ducts into spermatic ducts to ensure spermatogenesis, and then convert the external genitalia into typical male. So we have now found a new sex, and that is genetic sex. Genes are important, not just genitalia, reproductive organs, gonads, chromosomes. You must have the Sry gene. Just as we thought that we understood everything, I'm going to now totally surprise you by saying it's not just XY or SRY that is important or totally determine the sex. It's the presence of androgen receptor, which is very important for proper development of secondary sexual characteristics as well as genitalia. So we have a new entrant, that is molecular sex. So finally, to determine the sex, everything should be perfectly matched. What do you mean by everything? Chromosomes, what is called chromosomal sex. You should have a clear-cut XY or XX. Genetic sex, you must have Sry gene if it is XY. Absence or presence of them will totally change everything. You will see that soon. Or gonadal sex, you must have a clear-cut ovary or testis. If you have ovotestis, then there will be a problem. Reproductive sex, you must have uterus, even in spite of having XX. If you don't have uterus, as in case of Arcade syndrome, there's a problem. Genital organ sex, you must have clear vagina. If there is just a dimple, then there is again problem. Molecular sex, as I told you, there should be receptors, androgen receptors, or absence or presence of them will determine. And finally, one more entrant, mental sex, that is the orientation. So when so many things have to be properly aligned, you should really think, is it fair to point a finger at people who do not have correct alignment of all these things? So chromosomal abnormalities, I want to talk a little bit. There are mainly non-disjunction during meiosis, which is called aneuploidy. Non-disjunction during mitosis, called mosaicism. Structural abnormalities or translocations or deletions. These are the main three varieties in the chromosomal abnormality. Let's take up one by one. Aneuploidy. Let's say the ovum which has got 46XX and the sperm 46XY at the time of meiosis, if there is non-disjunction, wherein one egg will get 24XX, both the sex chromosomes go to that particular egg, whereas the other egg, poor egg, will have just 22 autosomal and 0 sex chromosomes. Let's say there is proper disjunction on the male side. So one sperm will be 23X, other will be 23Y. Let's look at the combinations now. If these two combine, as you can see, it will be 47XXX. shall we call it super female? Whereas these two will give rise to typical Turner's 45X0. And these two combinations will give rise to 47XXY. As long as X is there, there is no problem, but it will be called Klinefelters. But this combination is 45YO. You may wonder, if 45XO can survive, why can't 45YO? Male is the weaker chromosome. It cannot survive without an X. We cannot survive without mother. So this is the one which is commonly seen, aneuploidy, in all these problems. Mosaicism, 2 or more cell lines. It can be 46XX or 46XO in the same person, or it could be 46XY, but another cell line can be 45XO. Obviously, there will be confusion in this at all levels: chromosomal level, genetic level, genitalia, genital organ, molecular sex, and orientation. 46XY, one line, another one is 47XXY, Klinefelter line. Confusion again. To add to all this, as I said, the third problem is translocation. The translocation of SRY containing short arm of the Y chromosome to the X chromosome, what we call XY interchange, can result in XX but male. Very, very confusing. Not so when you see the picture. So as you can see here, it will be like a XY, but this particular person who is actually having endowment of XX, but as you can see here, the short arm in this particular chromosome has been replaced by the Y chromosome, SRY containing short arm. We have just understood in the first slide, SRY determines everything. SRY is the one which writes a transcription to convert the gonads into testes. Testes will produce MIS as well as testosterone, and everything will become male. So here, even though the endowment is XX, just because there's a translocation of the short arm that contains SRY gene, even though this is otherwise female, everything will be like male. No uterus and external genitalia will be male. Yesterday, I was talking about Swyer syndrome while talking about primary amenorrhea and secondary amenorrhea. Here you can see the problem is due to deletion of SRY gene alone, nothing to do with the short arm or long arm, in an XY individual, resulting in XY but female. That's called the Swyer syndrome. We have seen this picture yesterday. As you can see, this is a perfect XY, but you know, in this individual, even though the rest of it is XY looking, but this SRY gene, the dark blue band, is missing. So that person will be phenotypically female. So having understood these things very clearly, now my job is hopefully going to be easy. Classification. The classification of Dsds can be mainly 2 categories: normal sex chromosomes and abnormal sex chromosomes. Under normal sex chromosomes, let us see what could be the problems. It could be masculinized female. She has got 46XX, absolutely no problem with the chromosomes. But there is a problem, that is CAH, congenital adrenal hyperplasia, which will give rise to clitoromegaly and micropenis. So there is congenital development of ambiguous genitalia. Perfect female. Problem is entirely outside the gonads and even the genital tract. Adrenal hyperplasia, but poor external genitalia will have to bear the brunt. Clitoromegaly, micropenis. The second one is incompletely masculinized male. Earlier it was masculinized female. Now it is incompletely masculinized males. That is because of a congenital disjunction of internal and external sex anatomy. The typical example is testicular feminization syndrome. The chromosomal endowment here is XY, but there is problem. So there could be complete or partial androgen insensitivity. As a result, the external genitalia, the person will develop nice breasts like a female, and of course the gonads are not really, sometimes even in the scrotal area, they may be in the inguinal area, and there is no proper development of the penis. Somewhat like this. So you think that it could be a female at birth. Then we have aberrations of sex anatomy only, which is incomplete development of sex anatomy, something like vaginal agenesis, perfect 46XX, or pure gonadal dysgenesis. So these are the three varieties in the normal sex chromosomes. Whereas in abnormal sex chromosomes, sex chromosome anomalies, for example, Turner's, as we just saw, 45XO, wide carrying angle, webbing of the neck. Klinefelter's, 47XXY, and sex chromosome mosaicisms. Or it could be disorders of gonadal development only, which is called ovotestis. Probably this is the one which is a true hermaphrodite, what we used to call in the past. Since congenital adrenal hyperplasia is the first one in the classification, what we saw just now in the normal sex chromosome, and that's the commonest, we'll deal with that more. Most common, 40 to 45% for the ambiguous genitalia. There's a Prader scale, 5 stages of virilization. This picture actually helped us in resolving or counseling one of the parents who were insisting on that they want a particular type of child. There was a confusion in the OT, and when the patient went to, the baby went to NICU, the NICU people told a different sex, and then the parents started making noise. This picture helped us. 5 stages, no virilization, stage 1, and by the time it comes to stage 5, it looks like a perfect male. It is not. CAH is an autosomal recessive inheritance. It has nothing to do with the sex chromosomes. It's a normal sex chromosome here. It results from a deficiency of one of the enzymes required for synthesis of cortisol. Reduced cortisol will give rise to obviously increased ACTH. Something like reduced estrogen will give rise to increased FSH. That will stimulate the zona reticularis. Obviously, there will be increased androgens from the adrenals. So there won't be Olympian development in spite of some amount of androgen, because it requires high local testosterone. The adrenal androgens are not so very strong as testosterone produced by the testis. So there won't be any Olympian development in this particular person. The person will remain female. There won't be production of sperms or anything like that. But the external genitalia, there will be enlargement, there will be clitoromegaly, and it will confuse us as to think that it could be a male. There is reduced cortisol. As a result, the other things happen. There is decrease in aldosterone. As a result, there will be electrolyte disturbance, such as hyponatremia, hypoglycemia, hypotension, dehydration, and hyperkalemia. This is a deadly, fatal combination. Unless diagnosed early, the baby is going to die. So what is important here? Is it important to know whether it is a male or female child, or whether to save the child? The most important thing in CAH at birth is to save the child of hyponatremia, hypoglycemia, hypotension, dehydration, and hyperkalemia. So the attention should be towards that, rather than determining whether it is male or female. I hope you all agree with me. The approach to Dsds hence should be patient-centered. The goal is the long-term physical, psychological, and sexual well-being of the patient. It needs well-organized, well-trained, and institutionally supported multidisciplinary healthcare team. The principles of patient-centered approach in this situation is it should provide immediate care when there is real and present threat to the patient's physical well-being. We should not worry much about what is the sex at the time of birth, though that is on the minds of the parents. The patient's or the baby's survival is most important. Then do not force the patient into a social norm that may harm the patient. The parents may want it to be a male or a female, but actually the child is something else. Don't force it into a social norm. Avoid stigmatizing terminology. Don't call it either hermaphrodite or pseudo-hermaphrodite. It is so painful for the child. Avoid parade of white coats. You may be interested to see a particular child which is having very abnormal features. So many doctors would come and see that and repeat it with genital examination. The child may not understand, but the parents, it is agonizing. Always tell the truth to the family and the child later. Respect parents by addressing their concerns and distress empathetically. Don't ignore them. Talk to them. Counsel them. After all, it's a life. Principles of patient-centered approach also in delaying elective surgical and hormonal treatments until the patient can actively participate in the decision making. There is no urgency to correct the sex of the child externally. There is no urgency to give the hormones and correct it. The only problem is probably aldosterone decrease, and that would give rise to all problems, which is life-threatening. Otherwise, there is no problem. So be sure whether they are truly needed for the benefit of the child or are being offered to allay parental distress. Treatment protocols, usually multidisciplinary team approach, and the team includes everybody: neonatologists, genetics, genetic counseling, gynecologists, child psychology, psychiatrists, pediatric endocrinologists, pediatric urologists, nursing, social workers, and others. A point of prevention: all attending healthcare professionals should behave in a thoughtful and calm manner. There is no scope for making histrionics. Oh my God, what is this? And all that. There is no need to say that. Avoid insensitive comments. Remember, privacy, confidentiality, and careful use of language will help reduce feelings of freakiness. Your demeanor should be honest, calm, sensitive, patient, and reassuring behavior that signals child is valued, lovable, and is a source of pride rather than shame. Actually, this demeanor should be there with every single patient that we treat, whether it's a child, whether it's a lady, pregnant lady, old lady, young man, old woman. Treatment protocols for the newborn: reassure the parents first and contact multidisciplinary team. Examine the child with the parents and family pediatrician. That's very important. No ICU if there is no emergency of adrenal crisis. CH is potentially life-threatening and must be promptly ruled out and treated in all cases of genital ambiguity. That is much more important than resolving the sex issue of the child. Karyotyping, of course, we have to send to get a clear picture. Genetic analysis, endocrinologic, radiologic tests as appropriate. Multidisciplinary case conference can be held. You have to provide appropriate case-specific, long-term, patient-centered multidisciplinary care. When the baby becomes child or an adult, the same steps are followed as before with the following differences. The consultation is less urgent because the baby would have already overcome the adrenal crisis. Now it's only the issue of solving the sex of the child. If the child is older, we have to be more careful while examining. Children should be encouraged to ask questions and voice fears and concerns. Provide peer support, especially during the child's social gender transition. This is the most important issue. Gender assignment. As I told you, we had a big problem in Manipal once. In the OT, the enthusiastic PG told something, and in NSU, the consultant told something else. And we had to sit and explain to the patient party. So it's an imperfect art. It's basically a social and legal process, not requiring medical or surgical intervention, actually speaking, at least at the time of birth. Role of doctor is to basically obtain and help interpret test results concerning etiology, anatomy, physiology, and prognosis. Thus, initial gender assignment is made by the parents itself. Let them decide. Whatever it is, it's okay. It doesn't matter much. It's after all a child. They say children are God. Doesn't matter, God or goddess. Rarely, child may attain puberty without clearly expressed gender identity also. Doesn't matter. We can be clear at a later date. There's no urgency. There's no health issue as such till puberty. The clinical presentation can be apparent female will have a short stature, probably maybe because of 45XO, amenorrhea for the same reason, streak gonads, oligomenorrhea, virilization, sometimes, if there is congenital adrenal hyperplasia, and obviously infertility. Apparent male may be short statured again, no virilization, but instead you may have gynecomastia, hypospadiasis and or cryptorchidism, inguinal hernia because of the gonads there, and then infertility for them as well. So I want to summarize at this stage that two really life-threatening issues, one at birth, adrenal crisis, one at puberty, the chance of gonadoblastomas, more so in PAIS, not me, it is partial androgen insensitivity syndrome, or it can happen in PAIs also, but less than 5%. So what's the timing of hormonal therapy then? Endocrinologic therapy, that is hydrocortisone and prednisolone, cortisol, or fludrocortisone, that is aldosterone, can be given in CAH at the time of birth to avoid an imminent threat to the patient's health. But the reproductive hormones, that is elective sex hormone treatments, can wait until the child is approaching the age of puberty. Estrogen replacement is considered only if you have removed the gonads in a case of PAIS or CAIS. Complications of hormonal therapy are there. That's why we have to be very careful in giving them. Testosterone treatment can result in prostatic hypertrophy, reduced fertility, changes in the libido, acne, male pattern balding, and high blood pressure. What about surgery? Which surgery? Surgeries are rarely needed in neonatal period. It is not at all urgent in many Dsds. Even in infancy, clitoral reduction can wait actually. Operations to end an imminent threat should be scheduled as quickly as possible. Only urgent surgeries may be to create a urinary opening if it is not there, or to remove a malignant tissue, or if there is hypospadiasis, correction of it. Genital cosmetic surgeries offered to relieve parental distress can be at a later date, much later date, at puberty or maybe after that, such as vaginoplasty in CAIS. There are complications of surgery. That's the reason don't be in a hurry to do surgery. There can be diminished sexual sensation, sexual dysfunction, chronic pain. Neovagina carries a risk of neoplasia, loss of potential fertility, and loss of benefits of endogenous hormones when you remove the gonads. So, for example, prevention of osteoporosis, loss of libido, and sense of well-being after gonadectomy. Fertility issues are there, of course. but you can solve them by either sperm or ovum donation, as the case may be. Of course, when you do that, IVF and ICSI are the only methods of achieving them. When there is no uterus in Arcade syndrome or in testicular feminization, surrogacy is the answer. There can be primary amenorrhea in these patients. Yesterday, I have taken a detailed class, but today I would just snatch 5 slides from that talk. The clinical approach: breast absent, uterus present. Breast absent means lack of estrogen production. It could be because of HPO failure, either HP or O. I will teach you how to differentiate later. Or it could be Turner syndrome due to streak gonads XO. Presence of uterus means there is Y chromosome or Sry gene. How to distinguish? FSH estimation will solve whether it is HP failure or ovarian failure. If it is low, HP failure. If it is high, ovarian failure. But how do you differentiate between H and P? Give GnRH stimulation test. After giving that, if there is production of LH, that means hypothalamus was at fault. But in spite of giving external GnRH, if pituitary is not producing enough FSH, that means pituitary is at fault. Second situation, breast present, uterus absent, means ovaries are fine here. Uterus is not there, that means it could be the Arcade syndrome if the chromosome is 46XX, or if it is testicular feminization syndrome where it is 46XY. How do you distinguish? You can estimate testosterone. In our case, female level. In TFS, it is male level. Last situation, breast absent, uterus absent. Very sad situation. There's lack of estrogen, gonadal agenesis, and lack of uterus. If it is female Arcade syndrome, if it is male testicular feminization syndrome, or PICE, partial or size, complete. Karyotyping will solve the issue here. If it is 46XS, Arcade syndrome. If it is 46XY, TFS, testosterone, obviously in these patients at the female level. How do you manage hypergonadotropic situation? Chromosomal study should be done. If it is XY, gonadectomy at puberty, vaginoplasty, estrogen, and adoption, because they don't have uterus. Or you can go for surrogacy. If it is XO, Turner's, cyclical E plus P to promote feminization and prevent osteoporosis. Who said donation is the only way? They have uterus anyway. If it is XX, it is Swear syndrome, Savage syndrome, or ovarian resistance. What's the treatment? Same as XO. If it is eugonadotropic, the problem is that of the uterus. U means uterus, I told you yesterday. There's absence of uterus maybe. Do a chromosomal study again. If it turns out to be testicular feminization, same as previous slide, gonadectomy, vaginoplasty, estrogen, and adoption, or surrogacy. If it is XX, it has to be Arcade syndrome. So only options are creation of functional vagina for sexual activity, surrogacy for having child. With cryptomenorrhea, you can consider hymenectomy, vaginoplasty. Hirsutism, mechanical removal of the hair. Finally, hypogonadotropic and others. Hypogonadotropic, you have to give gonadotropins, FSH or HMG, which consists both FSH and LH. If there is hypothyroidism associated, thyroxine, pituitary tumor surgical removal, hypothalamic and pituitary dysfunctions, you have to treat with cyclical estrogen progesterone. For fertility, ovulation induction with HMG. For nutritional problems, nutritional manipulation. So what's the carry home message? DSDs are complex disorders of chromosomes, gonads, reproductive ducts, external genitalia, genes, and the receptors. Multidisciplinary and patient-centered approach is important. Behave in a thoughtful and calm manner. The real dangers are only 2. At the birth, it is adrenal crisis. At puberty, gonadoblastomas. Gender assignment made by parents on professional guidance. Karyotyping, genetic, hormonal, and radiological tests are performed as cases demand, and they will help in assigning the gender. Endocrine is initiated early in CAH only to avoid an imminent threat to the patient's health, the cortisols mainly. Surgeries are deferred till puberty unless urgent, like hypospadiasis. Sex hormone treatment also can wait until puberty, only after you have done a gonadectomy. For fertility, you have to go for sperm or ovum donation with ICSI and surrogacy. What I would like to say is that we are human beings, not just chromosomes, genes, gonads, or genital organs. We deserve and crave for love, irrespective of them. So we should give it to them. Let's give it to them. Thank you very much. Tomorrow there won't be class because tomorrow there is a KCOG skill transfer talk by Dr. Parul Kotadwala. So I will meet you day after tomorrow. Thank you very much for your patient listening.